Hello, this is Dr. VanderWel. Thank you for tuning in. This is the Eviva Weight Loss Treatment Options virtual seminar. Let's get started. So, who are we? So, Eviva, we are a bariatric surgery practice. We do all sorts of weight loss, medical weight loss, surgical weight loss, nutrition. Been doing bariatrics for almost 20 years. Been leaders and innovators in this field. One of the first in the Pacific Northwest to do a laparoscopic sleeve. One of the first in the world to do an outpatient laparoscopic sleeve and gastric bypass. Part of a bunch of papers that were initially contributing to field of bariatrics, and now we're the first practice in the Pacific Northwest to do an endoscopic sleeve gastroplasty, one of the busiest in the Western United States. Here's our team. We've got 3 bariatric surgeons, bariatrician, medical weight loss ARMP, 2 RDs, and 2 surgical PAs. Great team. I love working with these guys. We get together on a regular basis to talk about patients, talk about issues, talk about ways of always making our process better, making the patient experience better, making sure patients are doing really well. So this is always an important part of this talk: is why is obesity so hard? I like to take the 30,000-foot view, which is our genetics, our bodies are not made to survive in the 21st century. We're made to survive hardship and scarcity. Now we just have generally comfort and abundance relatively compared to any other time in history. Our bodies are made to live in austere conditions. They're not made to live in climate controlled rooms and work situations for many of us most of the time. The jobs that we do are considerably less difficult from us on our body standpoint. The types of ways that we method our transportation methods and the types of food that we eat and the way that we make it and the way that we store food, all of these things are completely different. All of them really lean towards making it much more challenging to maintain our weight as opposed to keeping our weight, less. Your body essentially always thinks that starvation and famine are coming and that you're not going to survive the winter, so you need to eat as much calories as you can every time you get a chance. We need to hold on to those calories. And whenever they're low, when you get deprived of calories, your body says, whoa, 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 we need to turn down the volume here on our usage. And it actually turns down your metabolic rate, making it that much harder to manage to actually lose weight because it doesn't want to burn your storage just because it thinks it's in starvation. Obesity. It's a disease. It's a complex disease. I break it into 6 things: mindset, diet, exercise, psychology, support, and biology. When you struggle with this one, it doesn't seem to matter how much your act together you have on this hand, you're just fighting this uphill battle against your body. And surgery is a really good tool to help us with this. It's just a tool, though. It's not a cure. It's not a magic wand. It's a really good tool. It changes that uphill battle that you're fighting into a downhill battle. So you're working with your body as opposed to against your body. So the constant, the tireless adage, right, of eat less and exercise more. Why don't you just do that if you want to lose weight? This is a great example. The most extreme example of this, honestly, is the Biggest Loser show, which, most of those patients go on to gain back all their weight back, and most of those patients go on to get surgery. I've actually done surgery on Biggest Loser contestants. And unfortunately, if you are obese, the chance of you maintaining your weight loss long term into a normal weight is less than 5%. In 5 years. It's just really hard. And I think most people out there have experienced some yo-yo where they manage their weight and it gets a little bit better, and then it goes back up and it goes back up and it goes back down. And that's the biology that we're fighting. That's that biology piece. So what are the treatment options that we have for this? So we have the eat less and exercise more. This is still on this hand, right? This stuff is still important to improve, and almost all of us have room for improvement in our lives and consistency. So that's still a part of this journey, and that's still something that we work a lot on. But to say that this diet and exercise is going to take you the distance is just not realistic. It is not, it's been, essentially you can't depend on this as a public health intervention that, we're going to be able to cure the obesity epidemic in this country and in the world. It's frustrating and disappointing. The weight loss results are poor, and the diability and durability, it's not very good. So let's talk about the next tool. That's the least invasive next one, and that's medication. And we're going to break the medication into non-injectable medication and injectable medication. So the non-injectable medication, so this is medications like appetite suppressants, like phentermine, or things that reduce cravings like topiramate, sometimes naltrexone we use, and a bunch of other myriad of medications that we've been using for a while to help with medical weight loss. And these can do okay. They can make some progress for some people, and I think they're tools. They can get you going in the right direction. The nice thing about these is that generally side effects are pretty manageable. There are always side effects for some small amount of people that might have something that they don't tolerate. Some drugs, they can try something else. But weight loss is generally slower, it's less, but this can be a good tool to kind of, sometimes people describe it as reducing some of the food noise or appetite going down, so you can just like feel like you can think about, get on with your day and live your life better. So these can be really good tools still, and they still have their place. Next thing we'll talk about is the injectable medications. So these medications are the ones that have the semaglutide generally is the base, or tirzepatide, that's mounjaro. So semaglutide is Ozempic or Wegovy. And these drugs are fairly new, and it's been very exciting. They're seeing much better weight loss than we've seen from many of the other drugs in the past. And yeah, they're generally well tolerated. Can be some nausea, maybe some diarrhea. Depends on, just depends on the patient. Some patients have some symptoms that are pretty bad and they actually can't continue taking them. Some people don't have any. So it just depends. The downside of these medications is that they can be very expensive. They can be very hard to find, even if you do have, coverage for it. We don't have as much long-term data, so we don't have years of data on these drugs. But, so far it looks strong, looks good if you stay on the medications. When you come off the medications, it can be very challenging to maintain your weight loss. So, these have been a really cool tool for a lot of people and a really great option for people that are not looking for a procedure. There really hasn't been something like this out there before. But so it's great. It's great. We just need more tools to treat obesity. So now we're going to transition into the part where we talk about procedures. So these are the next thing. Oh, that's semaglutide. There's tirzepatide. So let's talk about the endoscopic sleeve gastroplasty, the ESG, the endosleeve, or sometimes called the accordion procedure. This is a really cool newer procedure. We've been doing it in our practice for almost 4 years now. It's almost 10 years old, and it's a really cool. You have the suturing device, and then it goes down through the mouth. It's on an endoscope, and it goes down through the mouth, and then from the inside, we're able to reduce your stomach. We're taking full thickness bites of the stomach from this large bag down to a small tube by taking bites of that and then crumpling it down. The benefits of this are that your stomach is smaller, so you can't have as much food. It empties slower, and also that cellular lining that's on the inside of the stomach, those are hormonally active cells. And when you reduce the amount of surface area that's in contact with food, it significantly improves your ability, all the other things that your body's like, oh, wow, man, I'm just hungry. I need this, I need that. It makes it totally manageable. It's a big difference between that uphill battle and a downhill battle of working against your body as opposed to working with your body. We see about 20 to 25% total body weight loss in our practice. The durability seems to be good. We don't have as much long-term data as we do as the laparoscopic sleeve. We have more long-term data on the ESG than we do on the GLP-1 medications. We are getting, the downside is that it's self-pay still. We're starting to make some progress. Some steps have been taken into getting insurance coverage, but not quite there as on a prime time level. We don't have as much. So we have a 5-year paper that says looks like the durability results are good. A 3-year paper with thousands of patients in it that the durability is good. So that's really, really positive things. But I tell people that this is a tool. You got to take care of it. Otherwise, you'll wear that tool down. But really what that means is that you just need to make sure that your portion sizes are not pushing the limits on a regular basis. And that's true, honestly, of any bariatric surgery. All of them, if you push the limits on a regular basis, you will stretch them out over time. Recovery is generally about 4 to 7 days, where you feel like, 2 to 4 days of that, you feel like, whoa, I don't feel very good. And then one morning you'll kind of wake up, you're like, oh, yeah, life's good. I'm all right. So most of my patients are back to work within a week at least. So let's talk about the next one, the big, really the gold standard, and that is laparoscopic bariatric surgery. This is the best tool for treating your weight, hands down, no questions asked. It's a really good tool. And the tools are, it's done through laparoscopic surgery, which is small incisions using a camera and those small instruments. As you can see here, we are able to do all this stuff essentially through a screen with just very small poke marks. And it reduces the size of your stomach. So this is a gastric bypass, this picture, where you have a small pouch of stomach here, and you bring intestines, and you reroute around the first part of the small intestine. So this has the advantage of having a smaller pouch that you can only eat so much food, a small amount of food at a time, and that food is bypassing the first part of the small intestines so that it doesn't get absorbed as quickly or as much. This is a very great operation for people that particularly have heartburn or have bad diabetes, and can be a really good tool for them. So the other surgery is the laparoscopic sleeve laparoscopic sleeve gastrectomy. The lap sleeve. This is that one where you take the side that stomach and you reduce it to that small tube and you remove the extra stomach. It actually comes out. So you have this left of this small stomach, this extra stomach here. I tell people all the time, this surgery right here and the ESG, they're giving us a 21st century stomach. We do not need that much stomach in the 21st century. When we have Costco and refrigerators, we are going to be just fine with not having this major capacitance organ. You can fit over 1.5 liters inside of some of these stomachs. And back in the day when you got the gazelle or when the harvest came due, you needed to pack away as many of these calories before they went bad. But nowadays, that's not generally our problem. It's kind of the opposite, and that's why we don't really need these size stomachs. So, we have doing a lot of these. We actually do a lot of these outpatient even. And they do great. Complication rates very rare, less than 1%. But it's not, it's not zero. It's still a procedure. We still respect it. We still take it seriously. It is general anesthesia for this and the endoscopic sleeve. It's not always covered by insurance. So for many people, they have insurance, but some people don't. And we still have some self-pay options that are really competitive and still cheaper than a bathroom remodel. So recovery is about 10 to 14 days. And, I even have some desk job people that are going back to work within a week. So, oh man, one of these sounds good. It's resonating with me. You're stuck, right? You're like, I really need some help. Need to get going. Reach out to us at the Eviva team. Go to our website, evivamd.com/contact us. You can use this QR code over here. And set up a consultation. We do most of these telehealth. So you're able to visit with us from wherever you are. We have people from all over the United States and the world do consultations and surgery with us. And generally, we're able to do all of your follow-up with telehealth and just do surgery, on location, which is a really exciting thing, because that means that when you're struggling in the future, or you're like, hey, I got these questions or this or that, it's just where the access is so much easier to get help now. You don't have to drive all this way to get just a couple of questions answered, or just to try to get a small back on track. So this is fantastic. We've been really excited about this. At your visit, specifically the first one, we'll review your medical history, review your history, and just be like, hey, what's going to work best for you? We describe all these options, and you say, I think, I'm thinking about things. I don't know what to do. And I say, okay, well, while you're thinking about it, let's work on this, this, and this. And then you're like, no, I want to do this. I want to do this medication. Or I want to do this procedure. Like, okay, let's get started. This means this, this, this. Here's the things we're going to work on. Here's the follow-up we're going to do for that. And we make a customized plan for you, and we start the journey. So, not quite that journey, I guess. Yeah, and this is exciting. I think most patients, almost all of them, say it's one of the best things they've ever done in their life. And it's very rewarding for us at Eviva. We love doing this. We love seeing people's lives change and helping people and making their lives better. It's very exciting. It's very exciting. This is why we got into medicine, right? To help people make their lives better. And there's nothing like that when you can help someone with obesity. So, and who's struggling. All right, so that will start the, let's get going on the question and answer part here. Okay. All right. Let's see here. I think I got some questions that have come in. So thank you for joining us on the question and answer portion now of this talk after the virtual seminar. Let's see, here we go. Do you do a liquid diet after surgery or before surgery? Sorry. We generally do not. 99.9% of the time, we do not do a liquid diet. There are some practices that do a liquid diet to run it on the run up to surgery. That's generally not us. We have patients on what we call a liver shrinking diet, the pre-op diet. So that's 1,600 calories for men, 1,200 calories for women, with 40 grams of carbs a day max. And the goal of that is that it shrinks your liver down and shrinks the fat that's around your small intestines so that it gives you the most space for us to work. And it also kind of tunes up your cells for using less carbs as its primary fuel. All of the cells in your body want to run on some sort of fuel, carbs, fats, protein, or a mixture of the combination of all. But generally all of them, carbs are generally their preferred, most of their preferred ones. So when you work on transitioning yourself away from the carb piece to other sources of fuel, that can be a little bit of a difficult transition. And that's what they call like the keto flu and stuff like that. And it's not trying to get that extreme, but we are trying to really set your cells up for success for the post-op diet. So. All right. So we generally don't do a liquid diet. If you want to do a liquid diet, you're welcome to do a liquid diet, but it's not a requirement from us unless there are significant things like significant gastroparesis. Patients that are on a GLP-1, we do 4 days of liquid diet before surgery just to make sure everything's cleaned out of there because those GLP-1 drugs really do slow down stomach emptying, and we've done surgery where there's still food in the stomach before we started these policies. So, all right. I'm worried about vitamin deficiencies. Can we talk about that? Yes. Thank you for that question. So vitamin deficiencies are, that can be a real thing when you're losing weight. You need to have those vitamins are really helpful for making sure that your chemistry is working the best that it possibly can. And when you're eating less food, there is more of a risk that, you're not getting all the things that you would have normally. That risk is generally overstated. So most people think they need to eat a lot of food to be nourished. And really what we need to be doing is just eating nutritious food in an appropriate amount. We do recommend all of our patients take a bariatric grade multivitamin, which really does help optimize that chemistry while you're losing a significant amount of weight and taking in less food. And in the beginning, especially in the first month or so, your diet's much more limited because your stomach is still getting used to its new anatomy. And so you need to have a plan for that. We actually are recommending people watch their nutritious and take a bariatric grade multivitamin with some of the medications as well, because if they're losing a lot of weight, there's pretty similar things that can be happening, and we need to make sure that your everything's going as well as it can. So a laparoscopic sleeve, because it doesn't bypass any of the small intestine, is much less likely to have significant vitamin deficiencies. If we do see vitamin deficiencies, it's almost always that the patient is grossly not taking their vitamins and also not really eating very nutritious food or a balanced diet. Laparoscopic gastric bypass is a little different story. So the gastric bypass bypasses that first part of the small intestine like we saw before. And so that is a place where a lot of vitamins are absorbed, which it means that it is a part that we need to make sure that we're supplementing because your body isn't optimized for absorbing vitamins and some minerals in the later parts of the small intestine. So it is really important to take your vitamins after a gastric bypass. The chance of having like very significant pervasive vitamin deficiencies if you're taking vitamin supplementation is extremely low. And if you forget your vitamin supplementation sometimes, it's also considered very low. Usually when people have gross vitamin deficiencies, either they had an extreme bariatric surgery, like that we don't really do anymore, or their diet is very unhealthy. Yeah. So yeah, great question though. Great question. All right. Okay. The other question was, what does the process look like to get to surgery? So we talked about that consult in the seminar. You meet us, you meet your team, and we start putting in a place of what you need to do to be safe to get to a procedure. And generally, that is getting a set of labs, maybe get an EKG, and maybe a sleep study or something like that. It just depends. Do we customize that to what your needs are? If there's other doctors that need to weigh in on some of your health considerations, we make sure we do that. Our goal is that you're safe and you get through this procedure safely. So we just figure out what's the most important things to make sure that you are going to do well and be safe, and we put those in place. Some people's insurance, if they have insurance coverage for bariatric surgery, requires a supervised diet that is very dependent on from plan to plan. And so that may mean that you have to meet with someone from our team for 3 months in a row, or sometimes you have to meet, with someone from our team or a different team, even a specific team, or our team, and we do have to do 12 visits. It just depends on what that coverage says. We have coordinators afterwards that they just help, like, that are so experienced with this. All of them have done thousands, and they help us with guiding you through that step, and they stay in touch with you of like, hey, we got these things coming up, we got to make sure we're hitting these milestones, and then when all those things are, when that whole checklist is done, and hopefully for some people it's very short, and for some people it's a little bit longer, and we keep track of that. Whenever your checklist is done, we say, okay, we're looking towards getting cleared for surgery, getting your final insurance approval, and we can send them the packet of all the things that we've checked off the list, and then there we go. So it can be a little bit of a daunting process, but that's why we've done a lot of this. We've been doing this since the beginning of bariatric surgery, really 20 years ago, of modern bariatric surgery, because the gastric bypass is actually it was invented in the 60s. But really, so we've have a lot of experience with this, of really getting people through, and making this a good patient experience for you. You can check out, our reviews online, and, hear from us, hear from our patients that are out there in the world. Our goal is to treat people the way that we would want to be treated, and we get a lot of joy and a lot of, the reason we get up and get out of bed and come to work every day is because we want to see people do well. We want to see people's lives change and to help them. So, and yes, it's a great field. So, all right. Give another minute for questions. All right. Okay, looking good now. So thank you everyone for tuning in. Appreciate your attention, and you're welcome to reach out to us. We're always very excited to hear from you and looking forward to taking that next step. So, all right, have a great day.